by the hitting, slapping, punching, or it could be any kind of physical harm. Similarly, if you talk about the emotional abuse, includes the manipulation, intimidation, and threats to undermine the uh, victim self-worth. Then sexual abuse involves any unwanted sexual contact or behavior without the consent of the partner. Now, there are different warning signs. So there are many warning signs. There are about 10. And the most important component is if you could look at the upper portion where these four females are standing, 1 in 4 women will fall victim to domestic violence at some point during their lives. This is a very, very high and very alarming figure. And women in their early 20s are at the highest risk of suffering from the domestic abuse. So these two are very, very important points which should be considered in mind. Now, impact of the domestic violence. It affects the entire family. And 30 to 60% of the intimate partner violence cases also include child abuse. So most easy victims are the child abuse, and majority of this happens in the third world countries. Now, what do we have a law regarding domestic violence in our setup in Pakistan? If we talk about it, so we have a bill which was jointly that was like approved by the Senate, and it states that Islamabad Capital Territory, it means the federal government, defines domestic violence as all acts of physical, emotional, psychological, sexual, and economical abuse committed by a respondent against women, children, vulnerable persons, or any other person with whom the respondent is or has been in a domestic relation. So all these 5 points which I mentioned you earlier, these all have been covered in a protective bill which is given by Government of Pakistan. This is applicable in federal ministry as well as in all the 4 provinces of Pakistan. So what is it about it? I'm not going into the detail of this because it's not concerned with this. So do we have a reporting system? Can we report domestic violence? Does anybody know? Even I didn't know anything about reporting a domestic violence. When I go through this case and even when I started working on this presentation, then I go through the literature, and what I found that we have a helpline by the number of 1043. So this is for the workplace harassment, gender discrimination, property disputes, and inheritance right. And this is about the domestic violence hostels, daycare centers, and other facilities. Anybody can report it. Sindh government has a reporting system as well. The Punjab Women Development Department has a helpline as well. So we have different domestic violence act which are prevail in the Pakistani law. So again, this is slide about 1043. So Punjab Women Healthline. Now coming to this patient, which was the victim of the domestic violence. So I give you her brief history. She was a 14-year-old patient named Rizwana. She received in Lahore General Hospital on 25th of July 2023 at around 4 a.m. in the emergency department with the history of physical assault and domestic violence. When earlier I told you that this kid was handed over to her mother, her total body was covered. Her face was covered with a face mask, and her head was covered in a veil kind of a cloth. So at the time she was delivered to her mother, they were unable to identify that this kid has got some injuries. What happened next? They took her to home, and in Sargodha, when they reached Sargodha after like 4-5 hours drive, that's through the bus, and they have another hour drive to their village. When they reached their village, they found that she was unable to move. They just picked her up, and when they exposed her after they just reached their home, they found that kid was brutally violated, and she had injuries on almost all parts of the body. I'll show you a few pictures. They just took this children to the district headquarters of Sargodha, and where she was given initial management. And fortunately, she was picked up by a health reporter. The health reporter took her pictures, and it was viral on the social media within a span of 1 hour. Immediately, the central government took action, and she was asked to report to Lahore General Hospital as she had multiple wounds on the head. I'll show you brief pictures. Now, the other aspect of this case is this was one of the challenging cases of my life for two reasons. Number one, she had multiple injuries. I'm going to and multi-system involvements, and the other, which was even difficult to manage, was these pictures you can see. The CM office, PM office, secretariat, director health, our own hospital administration, many of these child protection bureau start banging at 7:30 in the morning when I was about to take a shower till 1 o'clock in the night. So I used to receive almost 150 calls per day and 3 to 4 interviews on different media channels. Now you can see different pictures. She was managed on a very high ground. Here you can see he was the health minister at the time, Professor Javed Akram. Here you can see the current CM, Mariam Nawaz Sharif. Then we have Mohsen Naqvi, who was the ex-chief minister. He was on board. And apart from that, many other people, which I can list. Maybe it is in hundreds of the political figures who came to visit her. Now, these are the findings when she was first presented in Lahore General Hospital emergency. There were multiple wounds on her body. Now I'll give you the brief explanation of everything. On scalp, there was big infected wound, and it was suspected to have maggot invasion. On face, she had multiple wound with pus discharge. On back of the body, she had a big infected wound with necrotic patches. She had broken tooth and lacerated lips. She was severely malnourished and hardly was able to even breathe. She had fracture of nasal bone. She had bilateral ulnar bone fractures. So this was a brief presentation when she first arrived in the emergency and taken care by the Lahore General Hospital. Now, this is the picture. Just don't get afraid of it. I have virtually seen, and it was so painful to see this child. Now, here in the left upper corner, if you can see this cut here in the scalp, the maggots were coming out of the space, and this was all full of pus. Now, this is a big necrotic patch on the back, and you can see over the passage of few days, this got just start separated from this healthy skin. I'll show you other pictures as well. Now, this is the first management therapy which was given to her. The scalp was totally chopped off. Total scalp was chopped off. This is all brain matter, which you can see here. Then you can see this necrotic patch, and this is the area, this area down in the spine. It was in direct communication with the spinal cord. Now, here you can see the eyes. These are cheeks. These are the broken teeth, if you can see them. And look at the eyes. She was unable to open her eyes. 5 to 7 days treatment, she was able to open the eyes. Now, here you can see another huge cut, and this is an area again which was chopped off later on. Now my first question to our audience, to our colleagues and our PGRs, what should be the first line of management in this case? Now you have a brief history, and you've seen and you've gone through the pictures of the intensity of the wounds. Can anybody? So I'm starting getting responses. Very good. So we'll start with the ABC. This first response: whole body CT scan. Another. Yes. What else? Whole body scan. What else? Everybody is writing scan, come out of scan and think of something else as well. Primary survey, good. Resuscitation, very good. Fluid resuscitation, hemodynamics, focus, very good. Airway breathing circulation, fast, IV lines, blood cultures, very good, very good. Rehydration, antibiotics. We've got the picture how this patient should be managed. Now, our second question is, what are the initial investigation to be carried out for this particular type of patient? Hygiene maintenance. Very good. Very, very nice answers. I agree with everyone of it. And we actually manage the patient on these lines. Now, what should be the initial investigation apart from radiological picture? I'm talking about the blood and the related investigation. CBC, electrolytes, CBC, renal function, liver function, profile, blood CS, fluid CS, complete bloodstream. Very good. CBC, lactate. Who is this? Excellent. Umeric baseline, serum lactate, urine plus blood cultures, blood CS. Very good. ABGs. Excellent. Excellent. And regarding radiological, you guys said that you want to have a pan-CT scan. Sepsis protocol, myoglobulin levels, blood gas. Good. So I'm coming to the next slide. Now, this was the first line of therapy, which was managed by the surgical team. So at the presentation in the emergency room, she was thought to have septic shock, DIC, and multiple organ dysfunction syndrome. She was hypertensive, and she had generalized infection. She was badly smelling from every area. So they sent the baseline investigation. They just did a debridement of the wounds and back wounds, and she was shifted back to the surgical unit, the on-call unit. There she got unstable, and she was not able to maintain her blood pressure. And so what they did is they started norepinephrine infusion for the blood pressure support, hemodynamic support. And next day, like it was 4 a.m. in the morning, and she was shifted to the surgical unit by 7 o'clock in the morning. And at the around 9 o'clock, what has happened that the professor had a look on the patient and asked for the medical consultation. So what they did, the moment medical team reached at the site, they said immediately shift the patient to the ICU. This patient cannot be managed in a ward. So from there, from this point, we mean ICU team, they just get involved into this into the management of this patient. I'm audible to everyone, if you think I'm going fast, I can slow down my pace because it's a long presentation. That's why I just want to finish it quickly.
Sir, you are audible. Oh, yes, sir. You are audible.
So after the initial management, which I'm going to tell you in the next slide, what we did was that we constitute a medical board, and patient was managed on the lines of multidisciplinary approach. Now, what is the baseline of constituting a medical board right at this point? Can anybody answer? Team, can anybody answer why you should have a medical board for this kind of patient? Multidisciplinary team, very good. Multi-system involvement, okay. High profile case, that's very important. This is somebody who is working in a comment setup, I'm sure. Multiple injuries and legal aspect, very good. To have one on. Now, what we did, this anesthesia and critical care, why I've written it on the top was, why I've written on the top, because this was one department which was actually heading this critical patient. Everybody just walked away. Nobody wanted to take responsibility. And we were the one who actually took responsibility of the patient. So in medical board, what we did, we included general surgery, gynecology, general medicine, pulmonology, cardiology, dentistry, forensic medicine, plastic surgery, dermatology, orthopedics, and The last one is pediatrics. Okay, so these were different disciplines which were involved in the management of this patient. Okay. Now, what observation made by the multidisciplinary board? Number one, she was a victim of trauma and she was into multiple organ dysfunction stroke. These observations were made on the baseline investigation, which was sent by the surgical department. The patient was in septic, so we didn't have anything which can clearly state that patient is in septic shock due to one or the other reason. Then she had deranged LFTs and recurrent hypoglycemia. She was she had laryngeal edema. Uh, Please, can you switch off the mic? I think someone mic is laryngeal. She had laryngeal edema, facial injuries, eye injuries. Patient was in pancytopenia. She had low hemoglobin, low platelet count. So these were the initial observation, and patient was severely depressed. She was severely depressed. She was not even wanted to respond even to her parents. She was so annoyed. She was so angry. She was so much. She was in so much pain that she didn't want to talk to anyone else. And another thing which I forgot to mention, she had fracture of both ulna and had maggot in the scalp. Now coming to the different teams finding. Her GCS was 13/15 when she was receiving the ICU, and I still remember that she had a blood pressure of 70/30 with a heart rate of 140 per minute. That was regular. She was initially managed, and initial management and resuscitation started at the time, and I'll tell you the detail later on. Just go through the surgical findings. So she had a circumferential necrotic skin patch involving whole of the scalp, multiple bruises and superficial skin breaches, complaining of pain, irritable, having low blood pressure, and had decreased urine output. So she was already on norepinephrine. So what they planned that multiple release incision and minimal debridement has to be done once a patient is stabilized. They just prescribe IV fluids with broad spectrum antibiotics and analgesia. So these were the investigation which were sent. That was the complete blood count, CRP and lactate level, RFTs like renal function test, arterial gases, serum electrolytes, LFTs, and INR, and the pap cultures. And included, what we included was the toxicology screen because there was a suspicion that patient might have have a suspicion of poisoning as well. Viral serology was done, and she had her hepatitis B, C, and HIV were sent, and serum B12, folate, and iron studies were also done in view of severe malnutrition. Her chest X-ray was done immediately. At the time, her PET-CT was were advised once the patient will be stabilized, and ultrasound abdomen was conducted there at that time. We just put an arterial catheter, we put multiple IV lines, and later on we pass a central veins line as well. Coming to the dermatology finding, it's a long list of dermatology because she had very poor hygiene. She had bilateral periorbital edema with hemorrhagic erosions. If you talk about the lips, lip edema with two laceration, cut plus hemorrhagic tooth crusting. Oral cavity, she had dry tongue, coated buccal mucosa on the left side, single erosion seen. Bilateral post-inflammatory hyperpigmentation. The only good thing was she had normal genital mucosa, which shows that she was not victimized by a sexual assault. That was the only positive thing in this finding. They advised different local application. Now, coming to the gynecological evaluation and finding, again, everything was normal as far as gynecological examination was concerned. Now, coming to the edema, perhaps she was also hit on the neck as well. She had mid-line posterior cervical spine tenderness, was unable to lift her head off the spine. She was presented initially in the ICU. She had multiple ribs on the upper and mid-thoracic region were tender on the posterior side of the chest wall, again suggesting that probably she was hit with something. Maybe it was just blows or something, some instrument or whatever. A large patch, necrotic patch on the interscapular region, which I showed you in the picture. So what they advised that they wanted to manage the patient conservatively. They applied a back slap, and it was already there. They just refine it, or they advise a pan CT scan once the patient was hemodynamically stable. Now, their plan was back slap on both forearm, X-ray CT, that I've already given you about this. Now, psychiatric evaluation is very important. Due to a critical medical illness, she was unable to communicate properly. And another thing I would like to bring into your knowledge that this child was away from their parents for last 1 year. In last 1 year, she had just one meeting, very brief meeting with her mother 6 months back from this incident when she was brought to hospital. And so she was psychologically so much upset that she even didn't want to talk to anyone. Even she refused to eat anything. It was not possible to assess her mental state examination at present moment. Coming back to the slide, it was advised to manage her physical complaints and ensure vital stability before moving on to the psychological psychiatric management. Similarly, if you just have a look on the ophthalmology evaluation, she had bilateral lid edema, skin abrasion, both upper lower eyelashes, they were matted, bilateral conjunctiva, ecchymosed, lengths were normal, and on undilated pupil, dilated further examination needed, and it was decided to perform once patient was stable. So they advised some local application. Now, to sum up, what all has been observed by different disciplines, the patient had unstable hemodynamic and vasopressor support to maintain her blood pressure. She was a victim of polytrauma because she had multiple injuries at different areas. Patient was in septic shock and the cause to be determined. She was in pancytopenia. She had deranged LFTs with deranged coagulation profile. Recurrent hypoglycemia. She was going into recurrent hypoglycemia because she had not enough intake. She had laryngeal edema, nasal bone fractures, fracture ulna, both forearms, and like this is, I'm going to give you a picture of first 24 to 48 hours. So what we did, with admit and keep the patient in the surgical ICU, we started resuscitation and management side by side. As I told you, we just passed a central venous line and arterial line. Intake output monitoring started, and we just put her on the broad spectrum antibiotic, keeping in mind because we didn't have the exact idea for which is the focus which is going to cause this infection and the rest of the thing. All supportive measures were started and wound debridement as advised, but it was done a day later. She was put on TPN and later enteral nutrition was started once her clinical conditions settled down, and we sent all the essential lab and pan CT scan and toxicology screening were sent. Now coming to the course in the ICU. When we received the investigation, she had high CRP, high lactate level. Her TLC count was high. She had low albumin, deranged coagulation profile, and LFTs. Her RFTs were borderline high, but they were in the normal limits. She had low hemoglobin count along with low platelet count, and what we did is that instead of because she was 22 kilograms kid of age 14 years, so we were very cautious about giving her liberal fluid. So what we thought that we start giving her a Paxil volume, and along with that we'll transfuse her with the platelets and FFPs. This was started, and it took us almost use these couple of fluids, and even we just gave her a cover of diuretic as well to avoid fluid overload, but somehow she developed pulmonary edema and she became oxygen dependent. She was on oxygen already when she arrived in the ICU, but the amount of oxygen required to maintain saturation increased. So what we did is we tried to manage on the line of trolley, and pulmonary edema was managed conservatively. She was given diuretics, supplementary oxygen, and she gradually improved over a period of few days. And intermittent, she was given a trial of the BiPAP as well. In next few days, like 2 to 3 days, maybe 4 days, she developed bilateral pneumonia, and she was already severely malnourished. And the patient extensive debridement of the wound of the scalp was to be done under general anesthesia, because it was the usual consensus, if we are not going to remove the focus of the infection, we won't be able to save the patient. Now, once she started deteriorating, her ABGs showing the picture of type 1 respiratory failure, along with the increased lactate, her X-ray showed bilateral pulmonary infiltrates, and it was suggested by everyone that we should ventilate the patient. I would like to ask the house, everybody sitting who is here, what should be done? Should we go for elective ventilation at this moment, or should we be continuing with the conservative management? Can somebody answer? So far now you have got enough information about this patient. So if you have received this kind of a patient with this kind of scenario, intubation was a better option, conservative management, remove infective source. Okay, that's not okay. Intubate. If GC is good, then no need for intubation. Conservative, considering the amount of oxygen required and less of elective ventilation. So the people who were involved in the management of this patient, they were of the opinion that this patient should be electively ventilated, and later on we can see how we can how her course improve over the passage of time. But what as main treating physician of this patient, and depending upon my whatever experience of working in ICU, what I can see or what I can anticipate, once I put this patient on the ventilator, I won't be able to take her out. The way she was extremely malnourished. She was having high lactate. She was having high TLC count, low albumin, multiple. She already had been through a trolley and pulmonary edema. So I was very worried that if I'm going to put her on ventilator, I would be take her tube out. I discussed with the pulmonology, and what we thought. Patient had a very poor effort, and whatever effort she made, we could just hear the gurgling of the secretion in the major airways, and there was a lot of crepitation in bilaterally present in the chest. So I don't know, it was a brave decision or a stupid decision, but I took a challenge. I just put her on a laryngeal mask airway of 2.5. We passed a bronchoscope through this laryngeal mask airway. We took out all the secretion. It was pussy, hemorrhagic, and copious secretion were there. And we just took her out, and dramatically, and I just extubate means I just took out the laryngeal mask after half an hour of ventilation, and surprisingly, she responded amazingly well. She responded amazingly well. But what happened, over another course of 2 days, she again deteriorated, and same situation was there along with the bilateral patches on the chest. Again, now pressure of putting this patient on ventilator, because what hidden trial I have done along with pulmonologist, that has apparently failed. But again, even whatever you want to say it, Again, me and the pulmonologist, we again thought of going and taking a chance of removing the excretion through the laryngeal mask air. Again, we just give her a little bit of the relaxant. We pass in the laryngeal mask airway. We just took out the secretions, and this time this hit like anything, and we were 100% on the target. And within a span of next 24 to 48 hours, her TLC count improved. Her lactate started settling, CRP settled down, X-rays showed dramatic improvement, and her oxygen requirement reduces to just a couple of liters in 3 days' time. Now, by that time, I'm talking about like 10 days of admission here. So medical board, they joined multiple times to review the treatment and progress of the patient, and they were just like there to fill in the blank, conservative management, do this, do that, whatever. Now our next question was to how to proceed for the surgery, because in that course we did her initial extensive debridement. So what we did that we call the plastic surgery team. Now, one problem in our hospital, it's not a problem. It's basically the logistical issues. We didn't have a professor in our plastic surgery department, and the department is headed by an assistant professor. For this kind of a high-profile case, it was suggested that if at all the surgery has to be done and you're thinking about a flap rotation or skin grafting or something else or debridement, a professor should be on board. So what we did, we request 3 professors of the renowned professor of Lahore. One is from the Burn Center, one is the ex-chairman of Sheikh Zayed Hospital, and one is the current professor at Mayo Hospital Lahore, along with assistant professor or our own hospital. They jointly sit with the patient. They discuss with the medical board. They just gone through the progress of the patient, and they decided that this is not going to be a one time or 2 time surgery. This is going to be the series of the surgeries, and for this series, the patient might have to go to anesthesia maybe for 5 to 6 times. This was their initial plan, and once they said we'll go with the debridements. Once the wounds are clear, then we'll just go with the skin graftings. And the flap rotation was totally denied, as the patient condition was not this much good that she may be able to bear a flap rotation surgery. So anyways, TLC, lactate, CRP, biochemistry, anemia due to long list of the investigation. These are our problem. These biochemistry, they just going dips, kabhi theek, kabhi galat, kabhi upar, kabhi niche. So that's how we just gone through in a roller coaster manner regarding the investigation of this patient. And at one time, we thought that we are doing too much testing, and even she had anemia due to our over testing. So we just limit the amount of blood, and we reorganize and we rethink that too much testing is not required at that particular moment. So regular CS blood wound sputum cultures, they all were sent, and the antibiotics too. And to your surprise, every time, I think she had undergone almost maybe 15 to 20 cultures. Every time, one thing which was positive was colistin. She was only responsive to colistin. So anyways, colistin was continued. The wound of the scalp were deep, infected, and they were in need of an extensive surgical procedure. Orthopedic team, they plan to manage the patient conservatively. ENT team, they also said we're going to manage the patient on conservative grounds. She remained admitted for 3 months in hospital, in which she stayed almost for 28 days in ICU. The other challenge was nutrition. The patient didn't want to have anything orally. So initially, we just go through the TPN, and later on, we started to have enteral nutrition. Now, keeping in mind the psychology of the kid, she just wanted to have KFC, pizza, Lay's chips, some chocolate, and candies. This was all which she used to have. Any kind of ensure, any kind of milkshake, everything she just denied. So what we thought, that whatever she's taking, just let her eat. And what happened, that over like another like 45 days, she just started to having improve in the weight of this patient. To tell you the truth, first time she communicated with her family after 15 days, and she started to communicate almost a month. Now that's how we just at the course of this patient, we go through the regular relevant investigations. Management and treatment were according to the investigation lines. Regular visits from the nutrition department, physiotherapy department, and psychology department. The hospital administration managed all medicine, surgical procedures, food, and nutrition, and she was kept in a separate area with strict peri nursing. And to tell you that for these 3 months, she was even when she was shifted in the isolation and later on in a private room, all nursing care was provided by the ICU nurses of her of LGH. So this is my question to the audience. What is the role of nutrition and how it should be managed for in this kind of a patient? Can anybody enlighten me that what is the role of nutrition in this kind of a patient? What is the preferred route of nutrition? Parenteral. Good. Okay. Parenteral, healing, proteins, nutrition with all 3 components. Okay, good. फायदा क्या होता है nutrition का हमें? I'm asking about what are the benefits of enteral to provide energy to heal? Okay. What is the role of enteral feeding in sepsis? What is the role of enteral nutrition in sepsis? Can anybody? Benefit in immunity, provide energy in healing, enteral nutrition in sepsis. Patient loses 40 kilocalories per kg. That's carefully Sheikh. This is the correct answer. It prevents the translocation of the bacteria and it helps in the prevention of the sepsis. So what are the important ingredients and which should be the part of this particular patient? As you've gone through all these, what should be the important component in this particular patient? Protein, yes. Protein, carbs, she needs everything, but more of the protein. Okay, coming to the next slide. What is the difference of trauma which you see generally in our setting, like RTAs and the victim of the history of fall, burns, natural disasters? So what is different from in this domestic violence from the acute trauma? Can anybody tell me? So this is how we manage the trauma. This is on the ATLS guideline in which go through the A, B, C, D, and E. That is airway, maintenance of vital spine protection, ways for breathing, circulation, disability, and exposure. Okay. What's different in this patient? That this patient, as I mentioned you earlier, this was a patient who was actually not a victim of trauma in an acute setting. Whatever she had actually chronic injuries, and our forensic department told us that perhaps this is due to the chronic violence which she has suffered over a passage of time. They thought these injuries were almost 2 to 3 months old. Now coming to the what are the recommendations which we should make regarding the domestic violence? Educational programs both for men and women, enough opportunities for employment for women in the political parties, thinking of all types of domestic violence, crisis centers for violated women in the main healthcare centers, awareness program in collaboration with the NGOs, religious scholar involvement in the rights of the women, alcohol production, transport, and drinking, all should be banned. Now, these are the international guideline preventing domestic violence clinical guideline on routing scheme. This is from some area of the Europe. I'm not sure about. I just pick it from the net. This is again domestic guideline for the healthcare professionals, and these are the international law which are in the favor of the domestic violence. Universal Declaration of the Human Rights 1948 में बनाया. Then we have an act in 1979. Then we have an act in 1993, 1995, 2011, 2015, and 1989. These are from the various countries in which even Turkey is included. Now, this is the course of this patient. This area, it contained maggots. I've shown you this picture before. Now, these are the different pictures of the debridement where necrotic tissue and rest of the things were removed. The wounds were cleared. They were washed with the pyodine, some healing solution, some healing antibiotics, and creams were applied. This is the after 3-4 debridement. You can see there is a healthy wound underlying this area. And this is the grafting of the back, and this is the grafting of the scalp open area. She was put on vacuum dressing at the head and at the back. I'll show you the pictures. So this is the vacuum dressing. It caused a lot of trouble to the patient, but somehow it is very, very effective in the prevention of infections. Now, what were the challenges? This was a highly stressful administrative case in which I told you that so many officers were involved, and then media pressure. The media pressure is one of the worst thing which I have faced, particularly in this case, because this was the headline of every news channel. So daily I'll have to appear in 4, 5, 6, 8 interviews just to elaborate the picture. Anyways, it was a difficult clinical scenario. As you have seen, she has got multiple multi-system involvement. Then challenges of maintaining the IV line and the invasive line. Just imagine she has undergone 13 surgeries. Repeated infection, and the only thing was she was responsible was colistin, and I was truly afraid of the renal side effect of the colistin, and that's why every 3rd day, 4th day we have to go through the renal profile of this patient, and this was the last thing which happened to her. She became HBs positive after last surgery. When we were about to discharge her, her bilirubin raised to 20. Her enzymes raised to more than 3,000, but Alhamdulillah, we just managed her conservatively, and she came out of it in a span of around 25 days. These are different recommendations from the different sources. So I finished with this, that all is well, that Enwells. So this case was a perfect example of multidisciplinary approach. The other thing which I thought retrospectively, what was the difference? We generally put a lot of effort on all patients. What was the difference that we were able to save this patient? It is multifactorial. It is multifactorial. She was totally managed at consultant level. Totally. There's hardly any involvement of the PGRs. She was managed SR and above. we had unlimited funds. Food and nutrition by the hospital administration, everything was like these back dressing. They're very costly. I'll tell you the exact figure of finances which were involved in the management of this patient. We maintained strict isolation to prevent infection once she was stepped down. Dedicated nursing staff, I told you that was all through the ICU. Outstanding job by the psychiatry, psychology, and physiotherapy department, and obviously the plastic surgical team. He underwent 13 surgery under GA, and hats off to the ICU and anesthesia team. My right hand, Dr. Saqib Shahzad, was the one who was involved in every surgery. I was part of almost 5 or 6 surgeries.
Have you concluded, Dr. Jodat Saleem, or
This is the last picture. Just have a look. This is how she is.
okay? Now, can you hear me, Dr. Jodat?
Giri, yes, I can.
Amazing.
This is my life slide. I'm done.
Thank you very much. Thank you very much, Dr. Jodat. I was really delighted to hear each and every word of you. You know, and it was a perfect bookish management of this patient. You know, and you can see the messages, you know, which are pouring in, you know, in favor of your lecture. You know, and everybody definitely enjoyed it. I completely agree with you as far as ventilation was concerned. You know, and it is very, very difficult, you know, to take out the patient out of ventilator, you know, when you put in, you know. So probably it was a wise decision. And in the era of high flow nasal oxygen, you know, and non-invasive ventilation, probably it was a right decision. I agree with you. Now I would invite the audience, you know, to question, you know, if they have any question, they can ask. We have short of time, definitely. It is already 9 o'clock. But again, you know, we can ask the questions if the audience is keen to ask any question. Please, everybody is welcome to.
Please feel free.
Dr. Jodat, I do not have actually a question about this presentation, but here I would like to say that the work done by you was excellent, and I do not have really words to appreciate you. This is all from me. Thank you.
Thank you so much.
I don't
Professor
think
the Saqib from Nottinghamshire. First of all, I'm so proud that this work has been done by Lahore General Hospital team and the institute, where it actually has produced a lot of excellent anesthetists and ICU doctors. So hats off to you, hats off to the whole team. Again, it's a comment. I think you have covered all bases. It's a perfect example of multidisciplinary team management. And I would say that this was nearly an impossible case that you have reversed, and it's all your hard work and your team's efforts. So well done.
Dr.
Thank you,
Jodat,
Saqib. Thank you, sir. Thank you very much.
Dr. Jodat, can I ask what were the cultures actually? Which of the organisms you were able to isolate? I hope.
Yes,
please.
it was Pseudomonas. It was Pseudomonas and clapped every time.
Pseudomonas and clade. What about anaerobes?
Anaerobes. I was just trying to find her file, but it was taken by the administration because I told you it's a high-profile case. So
Right.
yes, that was the reason I was looking. I was looking for the file of this patient, but it has been removed from the ICU.
Right. And as far as I know, she was given cholesterol. But the culture was positive and sensitive to tigecycline.
Actually, I tell you that we are working in a government public sector hospital. So
Right.
the place where our pathologist is working, we don't have that tigecycline culture kit with us.
Because the thing is that recently I found E. coli in a knee, you know. It was post arthroplasty, you know, and it had PJI, and we found E. coli in the culture, you know, and it was MDR and tigecycline, you know, it worked excellently. So I really don't know If you go through it, you know,
actually,
exactly, it might help you in the future, you know.
yeah, actually, I told you that it's every cost has been bared by the hospital.
Right.
So if I can recall, I can't recall, in fact, how much amount of albumin she has been given, because she was losing a lot of albumin as well. Every time she went under surgery, there's a once we had all the dip in the labs, and again, you know, you have to build up in a 3-4 days. So there was a lot of challenges, but somehow I tell you that they were telling me that her total cost of treatment in staying in the hospital was around 4.5 million.
Right.
Because
And as
these
far as
surgical drapes and these dressings, the back dressing, one of these dressing, they cost 150,000 rupees. And like every time she went to surgery, she has been applied a new dressing and all that.
right. And have you any experience of PIC line over central line for long-term parental nutrition and antibiotics and fluids?
She was given a PIC line as well, but that
Right.
got infected because her both, perhaps I missed the picture, her both shoulders and the arms over the, like, the shoulder point, they were also infected.
Right. So that's why you avoided the PIC line, right?
We did try it, PIC line, but it didn't, she started again having fever, and there was a suspicion, there was cellulitis at the point of entry, so we just removed it.
Right.
It stayed there for like 15 days perhaps.
Then you relied on central line, that means.
We used the medicated central line.
Right.
The first one was ordinary. Then we changed the central line on wire. Then third was the PIC line, and fourth was the medicated central line, and finally we removed it.
Right.
So 4 times it was done. Yes.
Very nice. Thank you very much, Dr. Jodat. Thank you very, very much for delivering such a nice lecture. If there's any question from audience, you know, they are most welcome. Otherwise, we can conclude this session, you know. And again, thank you very much,
Sir,
Dr.
Rifa
Jodat.
here. Wonderful presentation. Very interesting to see how multidisciplinary led approach was done in a hospital like Lahore General Hospital, not undermining anyone's effort here. But mashallah, amazing. I'm just keen to know what was the duration of her hospital and the ITU stay.
She stayed in the ITU for like 28 days, and her total stay in hospital was roughly around 3.5 months. She was stepped down to an area, and later on she was shifted to a private room. And that private room was like, you know, it was like kept as an isolated area. And but throughout her course of stay in the hospital, she was managed by the ICU nurses. This was the main difference. I took all the opposition just to maintain the presence of ICU staff nurses with this patient, because I knew that if you're going to manage her in a step down area where just ordinary staff nurses are working, she's not going to make it.
Agreed. And Dr. Joe, there's a question from the audience. How you managed anesthesia with this patient, like fluid management and anesthetic drugs?
It was all routine anesthesia. There was nothing, nothing which you say we just go any. We just used we just used to pass the arterial line, and central line was there. We go for RSI, and she was maintained with the we have. Sorry.
Yes, please continue, please, Dr. Jodat. Please.
Okay. So every time, because every time we anesthetize the patient, she has to be moved in the prone position. So every time we use armor tube, and for analgesia we go for tramadol, and at time I used to get fentanyl from my private setup in a syringe, and we also used low dose ketamine and midazolam as well. The actual problem was not anesthetizing the patient. The actual problem was the recovery. And first 4 to 6 hours of the because we just pushed her directly to her isolation area, because her almost 45 to 50% of the body was under the different kind of bandages. So I was so afraid of the infections that we just, once we are done her surgery in the operation theater, for the recovery time, we used to keep her in the same operation theater for like half an hour to 45 minutes. When she was totally awake, she was shifted directly to her room.
Right.
The actual challenge was, sorry, I think your time is over.
It's perfectly all right. We can discuss. Dr. Hafdad is asked that did you use 5% albumin or 20% albumin?
That I can't recall right at the moment,
because
now it's almost 1 year old case.
Right.
I'll inquire it, and I have Dr. Hafdad number. I'll forward her the query.
Oh, right.
Assalamu alaikum, Dr. Jodat. I'm Dr. Talal, the General Secretary of PSA Karachi chapter, and I must say that it was a very good and enlightening presentation. And just on behalf of Pakistan Society of Anesthesiologists Karachi chapter, we are extremely thankful for the time and the effort you have taken to share your valuable insights with us. We look forward for the future collaborations and continue doing these kind of a lecture, and all of us will be learning under your guidance. Thank you so much, sir. Thank you once again.
Thank you very much,
My
Dr.
pleasure.
Talal.
There was just a query from Dr. Saira Asgar. She has asked, was she referred to some child safeguard? Yes, she was handed over to Child Protection Bureau, and I visited her twice there as well. So still she's in that Child Protection Bureau, and she said she doesn't want to continue the education. Now she is having some skills like cooking and perhaps stitching. That's 2 skills she's learning over there. Thank you very much.
Oh, probably you have answered this post of management that you were using tramadol and things like that. So this question has been answered already.
The tramadol, ketamine, and midazolam infusion. What I have seen in my experience